Hi, everyone, and welcome back to the Caregiver Empowerment Program. Today, we'll be focusing on the topic of obsessive compulsive disorder. My name is Alexandra Ferreira, and I'm a senior clinical psychologist in Nua Healthcare. In today's webinar, An Introduction to Obsessive Compulsive Disorder, we will focus on providing helpful information in relation to this mental health condition. This webinar has been divided into two parts. Part 1, an introduction to obsessive compulsive disorder, and Part 2, an introduction to obsessive compulsive disorder, how can you help? In Part 1 of this webinar, we'll be providing helpful information in relation to obsessive compulsive disorder, which going forward, I'll be referring to as OCD. We will cover the various ways in which OCD can impact on individuals and those around them. We will also talk about the psychosocial impairments that can result from having this disorder, as well as other mental health difficulties whose symptoms may mimic OCD, but the individuals do not actually meet diagnostic criteria to have OCD. In part 2 of this webinar, we'll discuss some ways in which you can support individuals with the diagnosis of OCD. We'll talk about what is important in an evidence-based assessment and the intervention procedures currently used in clinical practice to support managing difficulties, symptoms, and preventing long-term issues. This webinar is suitable for caregivers and family members who are concerned about a loved one who is struggling with OCD. In part 1 of this webinar, we'll be covering a series of topics. These include: what does OCD look like? How do thoughts and beliefs lead to such high levels of anxiety in OCD? How does OCD impact on a person and those around them? What other mental illnesses can mimic OCD? How can someone know if they have OCD? And what comes next once someone has been diagnosed with OCD? To finalize this part, we'll complete a summary of all the content discussed throughout the presentation and then move on to part 2 of this webinar. So what does OCD look like? OCD is a mental health disorder in which individuals experience repetitive and upsetting thoughts and or behaviors that cause significant levels of anxiety and emotional distress. Symptoms of OCD can vary substantially from one person to the other. However, symptom patterns do exist that help mental health professionals such as myself with diagnostic assessments. Individuals with OCD are commonly observed to engage in behaviors, which we'll learn to know as compulsions, to reduce the anxiety caused by their repetitive thoughts, which we will learn to know as obsessions. But this might not always be the case. Right at the bottom, there's a simple illustration of what might look like an OCD cycle. We'll elaborate further on the OCD cycle and pattern as we progress with this webinar. But the simple idea of OCD and how it functions is that individuals experience obsessions, so intrusive thoughts, that increase the levels of anxiety and result in the need for them to engage in compulsions, or in other words, behaviors. As the name indicates, OCD has two main features: obsessions and compulsions. Obsessions are repetitive and persistent thoughts, images, or urges that are intrusive and unwanted by the individual and cause high levels of anxiety and distress. Compulsions are repetitive behaviors that the person feels they need to perform to reduce the anxiety experienced from the obsession, even though they would many times prefer not to engage in these behaviors. When we talk about OCD, there are several OCD themes when it comes to both obsessions and compulsions. We're going to look at the most common obsession themes. I'll refer to additional ones because, as mentioned earlier, people with OCD can vary significantly in the symptoms that they experience, and that comes down to the obsessions they have as well as the compulsions that they have. In terms of common obsession themes, we have fear of dirt, germs, and contamination. I'm sure for many people who are listening to this webinar, this would be one of the main obsession themes that you are familiar with. Signs and symptoms of this obsession theme include fear of being contaminated by touching objects, others, and being touched or touching other people as well. Another one would be fear of acting out violent or aggressive thoughts or impulses toward oneself or others. So this might come off across as having images of driving a car into a crowd of people. I'll just remind you all that when we talk about obsessions, it is merely the thoughts that people have that are repetitive and unwanted. And these are ways in which they may manifest in people, but they might manifest in many different ways, depending on the person. Another obsessional theme includes excessive concern with order, arrangement, or symmetry. And signs and symptoms of this one include intense stress when objects are not orderly or facing a certain way. Doubting and having difficulty tolerating uncertainty is another common obsession theme, and it manifests in having doubts that you have locked the door or turned off the stove and made sure that everything is safe within the home, for example. And finally, we have religious superstitious beliefs, and these may manifest in having unpleasant sexual images in relation to religious figures. There are many other themes when it comes to obsessions. Some may include sexual obsessions. Some may include saving obsessions. So people thinking that they need to save certain objects that might seem quite trivial, such as cans or bottles, because there is the thought that they might be necessary in the future. And we also have somatic obsessions. So people analyzing their body and thinking and having, well, strong convictions that they might be ill or that they might die if they don't do anything about it. Similar to the obsessional themes, we have various compulsive themes. So when we talk about compulsions, I'll remind everyone that we're talking about behaviors, so typically things that we can observe in others. The most common ones are washing and cleaning. And if we think about that, this is very much associated and paired with the contamination obsession. So people who feel or have obsessions about contamination might engage in this particular compulsion pattern as it does help reduce anxiety. So, for example, signs of people who have compulsions of washing and cleaning could include hand washing until the skin becomes raw. Other compulsion themes include checking, so checking doors repeatedly to make sure that they're locked, or checking the oven 5, 6, 7 times to make sure it's turned off before leaving home. Counting is another compulsion theme, counting in certain patterns. So it could be counting numbers, it could be counting objects in the environment, whatever the case may be. Counting is used to reduce anxiety as well as all of the other compulsions. Following a strict routine might be another compulsive theme, and this includes, for example, silently repeating a prayer, a word, or a phrase in order to reduce that anxiety caused by the obsession. And finally, orderliness, so arranging canned food, for example, to face the same way. So all of these again serve the purpose of reducing and alleviating anxiety, and they all usually occur as a result of an obsessional thought. I'd like to highlight something here. When referring to compulsions, we refer to them as behaviors. So that would mean something that you'd be able to observe and how someone is acting and behaving. There are, however, compulsions that are actually mental rituals. So, for example, prayer. A person might pray, but they might be praying in their mind and not actually verbalizing the prayer. In that case, this is a mental ritual, and that something is going on inside, a compulsion in their mind. So, as a thought, another example would be, for example, having a positive thought in order to undo a negative thought. These are all examples of mental rituals that, even though they're not observable, they still remain as compulsions because the aim of these are to reduce the anxiety caused by an obsessional thought. So you may find yourself reflecting on some of these common thoughts and realize that there have been times where you have also had thoughts of this nature that were also intrusive and they're also unwanted. I'd like to reassure you that this is perfectly natural. We all experience intrusive thoughts. We all have them, sometimes more repetitive or sometimes not. And we all have thoughts that we consider to be bizarre, unwanted, or just very unpleasant. Sometimes those thoughts will be similar to those who experience OCD in that they may be similar in the themes experienced in OCD that we just covered. However, it is important to distinguish thoughts and behaviors that occur in the context of OCD and those that do not. So there are noticeable differences here that help us distinguish those thoughts and behaviors. So, thoughts and behaviors can be anxiety evoking and even debilitating from an emotional perspective for individuals that have OCD. However, people without OCD can process these very same thoughts and live their lives without being impacted by them. So, for example, we all may experience a thought like when we're driving on a cliff and suddenly having the thought that, oh, what if I turned the steering wheel and we went down the cliff? Or we all might have a thought pop into our minds where we get out the car actually and go make sure that the stove is off or the oven is off because we weren't sure when we left, but we'll do this once. But we all might have that thought on, did I actually turn it off? Did I actually lock the door? Or another example is we might have a sexual thought in relation to someone who might not be appropriate to have that thought about. So, for example, a boss or someone of the same sex if we are heterosexual. Or it could just be having superstitious thoughts, like, for example, seeing a black cat on Friday the 13th. We all have thoughts of this nature. Now, they might come to us and we might easily dismiss them, but individuals with OCD have a very hard time in dismissing them. And again, from these thoughts, they experience a very high rise in their anxiety levels. Thoughts and behaviors take up a significant amount of time in individuals with OCD, whereas in people without OCD, they're short lived. Again, we are very quick, if we do not have OCD, to dismiss the thought. We're very quick to say, oh, that's a silly thought. Or, well, that was a bizarre, strange thought, but it doesn't have much importance. And we move on from it. But because of the repetitive nature, and again, because the thoughts cause a lot of emotional distress, people with OCD typically become a bit more fixated and focused on these thoughts and the anxiety it's causing. And therefore, the thoughts themselves occupy the individual's time throughout the day a lot more than it would for someone without OCD. And the same applies for compulsions. We'll see that more as we go along throughout the webinar. Thoughts and behaviors in OCD can interfere with daily activities and interpersonal relationships, whereas individuals without OCD do not experience any interference due to thoughts or urges. So, people who may have, for example, the fear of contamination, they might touch a doorknob and have to go and wash their hands 5 times and using a very specific step by step way in which they make sure they cover the entirety of their hands to remove any potential germs. People without OCD might touch the same doorknob and they might think, there's a lot of people touching this doorknob, I'm about to go and eat, so they might go ahead and wash their hands once. So the level of interference will be different and it can heavily impact on a person's daily functioning. Individuals with OCD often feel the need to seek reassurance from others regarding their thoughts, whereas individuals without OCD do not share this need. So, going back to, for example, having a thought pop into our minds of sexual attraction to someone of the same sex, even though we have classified ourselves as a heterosexual. Sometimes we might think about this and immediately dismiss it. It's just a thought. And we might rationalize it and think, well, I just find that person to be very attractive. People with OCD, who again have this recurrent thought that causes them a lot of anxiety, they might reach out to their social network and seek reassurance regarding this thought. So they might seek out people that they trust and ask repeatedly, do you think that I am homosexual because I'm having these thoughts? And that there is also a compulsive behavior. The ongoing presence of these thoughts and behaviors may result in self isolation and avoidance of situations that may trigger the thoughts, so the obsessions. Whereas individuals without OCD, these thoughts do not impact on their engagement activities with others in any way. So, again, for example, if we're talking about someone who has an issue with contamination, they might have difficulties and struggling going to public toilets. So, they might get to a point where they do not access public toilets altogether, because of the fear and the impact that that obsessional thought has on their emotional well being. Whereas for us, and when I mean us, I mean individuals that are not diagnosed with OCD, we might have the same thought. Yes, I would prefer to use a private bathroom as opposed to a public bathroom. But if we need to, we will still go into it, we'll wash our hands, and we'll move on and go about our day without any interference. And finally, when untreated, individuals with OCD experience these thoughts and behaviors in multiple areas of their life, including home, occupation, interpersonal relationships, etc. Whereas individuals without OCD have thoughts and behaviors that are more correlated with the context and environment. So, for example, if we use a public bathroom, we may have a quick thought that this is dirty. There are definitely germs here. I need to make sure I wash my hands properly. I'm about to eat. So, in that context, we are thinking that, this isn't the ideal scenario. We might feel a little bit disgusted by it. We might have a thought that, I might get germs on me, thinking about other people's fluids. Our minds can take us all to different places. But in this example, we might have a similar thought to someone with OCD. But again, we engage in the appropriate measures and we dismiss it and move on and go on about our days. People with OCD that might have similar concerns, they might stop, as I said, going to public bathrooms. They might even stop going to their friends' houses because even though it is a bathroom within a home of a trusted person, they still might feel the fear of contamination. They might eventually stop leaving their home. This might impact on their ability to sustain a job because they might need to go out of the home to exert their professional functions. So these are just a few examples of how, if OCD is untreated, it can just continue to worsen in terms of the impact that it has on the individual, as well as the anxiety it causes in their day-to-day life. Let's look at John's case. John has a fear of contamination and therefore avoids going to public bathrooms. John is incapable of using a public toilet, touching the doorknobs of public bathrooms, as well as open taps, as he fears that these contain germs of other people that will make him ill. Not only does John avoid going to a public bathroom, he also does not drink any liquids 2 hours prior to leaving home, so he does not feel the need to go. John never accepts invitations to eat out or go for drinks, and he never goes to places that are more than 20 minutes away from home, in the event that he might need to use a bathroom, so he can go back home to use the bathroom. John does not have a job as he is not managing to find a location to work that is within a safe distance from his home. His friends no longer invite him to events and outings, which has had a negative impact on John's friendships. So if we look at John's case, we have the obsessional thought, the fear of contamination by using public bathrooms. When this thought pops into his mind, John's levels of anxiety and emotional distress rise significantly. In order to reduce his levels of anxiety, John engages in compulsive behaviors, which in this case are avoidant and safety behaviors. Avoidant in that he doesn't really go and attend certain public spaces because he is fearful that he might need to use the bathroom and he will not do so. Also avoidant because he's not willing to find a job and not willing to go beyond a certain radius from his house to make sure that he can access his bathroom whenever it is necessary. The safety behaviors that John engages in is, for example, avoiding drinking anything 2 hours prior to leaving home to make sure that he does not need to use the bathroom when out. Let's look at Mary's case. So Mary's engaged and is looking for a wedding dress for herself and dresses for her bridesmaids. Mary sees her friends try on their dresses and finds herself being sexually attracted to them and having intrusive sexual images. Mary starts feeling distressed and questioning her own sexuality and her decisions to get married to her fiance. Mary starts seeking constant reassurance from her fiance regarding their relationship and starts saying to herself repeatedly and mentally, I do not like women, I like men. Mary feels the need to repeat this to herself every time she sees her bridesmaids, looks at attractive women, or is in a room alone with other women. As a result, Mary is much less focused and less able to pay attention to conversations with women and the details in planning her wedding. So, again, if we look at that cycle, Mary's obsessional thoughts, which is fear of acting out intrusive thoughts in relation to her sexual images and attractiveness to women, this causes her a significant level of anxiety. And in order to reduce that level of anxiety, she engages in safety behaviors and reassurance seeking. Reassurance seeking is quite evident in reassuring that her relationship with her partner is a positive one and it's the right decision to make. And safety behaviors in that she tells herself mentally quite regularly and when triggered or when anxious that she does not like women, she likes men. We'll go now into the OCD cycle so that we can understand not only how this happens, so obsessions lead to anxiety, which lead to compulsions, but also how does this cycle maintain? So the OCD cycle represents the common thoughts and behavioral patterns observed in these individuals, regardless of what their obsessions and compulsions are. The OCD cycle provides a clear demonstration as how it is maintained over time. The anxiety that is generated by the obsession leads to the engagement in compulsive behaviors, which does promote a sense of relief and reduction in anxiety levels, as already mentioned. By doing so, we learn that it is a behavior that works to make us feel better in that situation. And this just increases the likelihood of us repeating that behavior, even if this behavior is detrimental to ourselves and to those around us. Furthermore, the cycle increases the frequency and intensity of obsessions. In other words, it does not target the main issue, it does not reduce the obsessional thoughts. So, on the right of the screen, we have an illustration of what a OCD cycle looks like. And we'll look at this example in particular. So in this case, the obsession is the constant thought about whether or not the oven was turned off even after checking once. So the individual feels anxiety about the oven possibly still being on despite having checked on it. So this causes a strong, uncomfortable feeling of anxiety, and the person feels compelled to act and to remove this discomfort. The tendency is to engage in compulsive behaviors, which in this case will be repeatedly checking to confirm that the oven is off, possibly going to the great length to do so, such as traveling all the way to home from work to make sure that the oven is off, even if there were several checks prior to leaving home. What this does is that when the person gets home, when the person checks, every single check they make, it does reduce the anxiety and there is instant relief in that split moment because the person can confirm, in fact, that the oven is off. However, the obsessive response has been strengthened for the future. So, what this means is that the person has an obsessional thought, it causes the anxiety, and when they engage in the behavior, so the behavior that reduces that anxiety, all the person has learned is that whenever I do this, I feel better, I feel safer, I feel less anxiety and less discomfort. And if we think about it as human beings, we all do things to make ourselves feel better, to make ourselves feel less anxious, to make ourselves feel more comfortable. We all seek pleasure and comfort, and we all run away from pain and discomfort. That is part of human nature. However, what we're doing is we're teaching our brain that this is the way to reduce our anxiety, but in fact, what we're doing is we're just strengthening that connection there. And we're just strengthening the connection between the obsessive thought and that compulsive behavior. In that the person thinks more and more, I need to do this every time I have X thought. So, like that, we instill an OCD cycle and pattern, which becomes stronger over time. And as it becomes stronger over time, we actually might see an increase in the frequency and severity of those thoughts and those behaviors. And might even get to the point where this individual, for example, might not even leave the home anymore, might lose their job because they're always leaving work to go and see if the oven is off. And therefore, it impacts on their life significantly, and things only get worse from there onwards. In order to prevent the activation of this OCD cycle, individuals engage in avoidant behaviors. These avoidant behaviors may be overt, so avoidance of situations or objects that trigger obsessions. Like in John's case, we see that he avoids going to public bathrooms in order to not have those levels of anxiety that are evoked by his obsessional thoughts. And they may be covert. What that means is that the individual might engage in thought suppression, which is an attempt to control obsessional thoughts. However, thought suppression may result in paradoxical increase in thought frequency, or at the very least, it intensifies appraisals about the thought's meaning. In other words, people, if they are not engaged in covert behaviors such as avoiding certain situations that might lead to anxiety, what they try to do is they try to actually address the thought itself to make it go away, to try and reduce their anxiety levels. Thought suppression would be a common strategy used by people, but this strategy is actually not a helpful one, as it strengthens the frequency of the thoughts. It might even strengthen the severity, or even increase the content, or lead to even worse content in relation to that thought. Also, it might make that thought even more important than it already is. And a way to show you how thought suppression is just not an adaptive coping strategy, we can use the example of what happens if you are told, do not think of a pink elephant. Usually, this is an exercise completed for a duration of 30 seconds. And commonly, people are unable to think about anything else, or they're unable to think about anything else other than that pink elephant. So, the fact that we're telling our brain, do not think about it, it actually brings the thought a lot stronger. The thought comes up more, it pops up more in our mind because we're actually trying to suppress it, we're trying to make it go away. So even though this is a strategy used in OCD to try and break that cycle, it actually strengthens it because, as you see in this example, the thought comes back stronger, more frequently, and it could be more intense as well in the way it's experienced. Going back to John's case, so again, John has a fear of contamination and therefore avoids going to public bathrooms. He is incapable of using a public toilet, touching the doorknobs, opening taps, again, because of the fear of becoming ill. So he also engages in the safety behaviors, as mentioned earlier, in that he does not drink anything 2 hours prior to leaving the home. And he also doesn't accept invitations to go anywhere out for drinks or dinner, especially if there are places that are more than 20 minutes away from his home. He's also struggling to find a job because John will not go and work in a place that is further away than he accepts. So He'll not go work in a place where he's not able to come back home to use the toilet whenever required. In John's case, and when we think about that OCD cycle, what it means is that John maintains the belief that he will get ill if he uses public bathrooms, and the frequency and intensity of these thoughts will increase over time. The possible increase in John's avoidant and safety behaviors and the impacts of these on his life might extend his avoidance to bathrooms in family and friends' homes. It might reduce the frequency with which he leaves his home, reduce the radius that he has considered safe around his home. He might not be able to manage to get a job or have and he might have financial difficulties as a consequence. And he might actually risk losing the current friendships that he does have. So the simple fact that John never exposes himself to what is causing all of this anxiety actually leads him to think that the avoidance is what's keeping him safe. Therefore, I'll continue to avoid it. Hence, increasing the frequency, intensity, and conviction in the belief that public bathrooms are not safe. Also, as already mentioned, OCD has a strong impact on individuals' day to day functioning. As we see here, the OCD cycle only means that things will only get worse over time if it is not dealt with. And going back to Mary's case, who is about to get married to her fiance and is making preparation plans for it with her bridesmaids. So Mary is starting to have images or sexual images in relation to her bridesmaids. She feels sexually attracted to them. And she has started to now tell herself that she does not like women, she likes men, and mental rituals that she tells herself every day or every time she's in a situation and confronted with these thoughts. And also, she's been seeking a lot of reassurance from her fiance in relation to their relationship and how it is a good decision to get married. So, in relation to Mary, the OCD cycle means that Mary Mary's increasing the frequency of her obsessional thoughts due to the meaning and magnitude she gives them. So the fact that a sexual thought popped into her mind in relation to a bridesmaid or an attractive woman, the importance and the meaning she's giving to it, whereby she's questioning her own sexuality, is increasing the frequency of these thoughts coming into her mind. The possible increase in Mary's safety and reassurance seeking behaviors and the impacts of these in her life may lead her to seeking constant reassurance from her husband regarding her sexuality, may reduce the contact with female friends and or not allow herself to form close friendships with women going forward, may avoid locations that may trigger this obsession, such as places where Mary may be exposed to women, including dressing rooms, beaches, locker rooms, etc. It may lead to more mental rituals as a form of repenting for her thoughts. So she might start praying if she is a religious person and feels this might be helpful and reduce her anxiety. And it may impact on her ability to carry out daily tasks due to frequent engagement in compulsive behaviors. Because if we look at it, there's a lot of avoidant behaviors coming up as well as safety behaviors, engaging in a lot of mental rituals, avoidant behaviors that again Mary didn't engage in before, and the impact that this may have on her life might be quite drastic. So while Mary feels that the behaviors she's engaging in are there to actually reduce the anxiety, but equally to reduce the uncertainty around her sexuality, in fact, the cycle she has gotten herself into is only increasing the magnitude, the severity, and the frequency of these thoughts. And that's also causing her more and more distress. And similarly to John, if not treated, if not addressed, Mary's behaviors to manage her anxiety levels in relation to this obsessional thought are only going to increase over time and impact further on her functioning. So, how do thoughts and beliefs lead to such high levels of anxiety in OCD? So, there are several components involved in OCD, according to the cognitive behavioral therapy model, which is a model useful to individuals and easy to follow that supports to explain how thoughts and beliefs result in such high levels of anxiety for those with the diagnosis of OCD. These include beliefs and the meaning given to these by the individual. So sometimes individuals may have beliefs that contradict valued aspects that they have in relation to themselves. So, for example, an individual that finds himself to be extremely competent and receiving a negative performance appraisal, this might lead them to have contradicting beliefs in relation to themselves. As a result, there is an increase in doubt, an increase in uncertainty, and consequently, an increase in anxiety levels. Another component considered is responsibility. This is commonly observed when people have obsessional thoughts around violence toward themselves or others. So, this responsibility element is when people feel responsible that something negative may occur due to their recurrent thoughts of it, and they also feel responsible to take action to prevent that negative outcome or the feared negative outcome from occurring. So, in that case, they resort to those compulsive behaviors in order to do so. Importance of thoughts. So, sometimes people attribute greater importance to their thoughts because people with OCD may struggle to distinguish thoughts from actions. And what that means is that for them, having the thought may be equal to doing what they're thinking. So, for example, having a thought of being sexually attracted to someone might mean that they actually have done or engaged in some sexual activity with that individual or indicated in any way that they are sexually attracted to that person. This lack of being able to distinguish thinking from doing does result in increased anxiety, but it also increases the likelihood of the person having more obsessional thoughts around this theme. Mental control is another aspect involved in OCD, and this has to do with the over evaluating of of the importance, so over evaluation of the importance and ability of one to control their own thoughts. So again, this takes us back to the thought suppression, where people think that pushing your thoughts away, trying to stop them, trying to control them will actually lead to less thoughts. But in fact, it actually leads to a greater frequency in those thoughts, as we've already seen. Um, but people with OCD typically feel that mental control does help, and mental control is a way to support in reducing the anxiety, although we see that it is part of the maintenance factor in that OCD cycle. Overestimation of threat. So, usually, this is when people perceive that whatever they're thinking might happen that is negative, um, they overestimate the severity or the likelihood of it happening due to the fact that they're thinking about it recurrently. Um, Intolerance to uncertainty. Now, we saw that that is an obsessional theme. So, a lot of people have difficulties with that, and that will lead to a lot of checking compulsions. But this really is about people with OCD feeling it impossible to tolerate uncertainty. And therefore, what they do is they go out and seek that certainty. And the only way they know how to do that is to engage in compulsive behaviors. And finally, we have perfectionism. This has to do with a tendency to believe that there is a perfect solution to a problem, that it is possible to complete a task without any mistakes, and even the tiniest of mistakes may lead to very negative, drastic consequences. How does OCD impact on a person and those around them? So the impacts of OCD will vary depending on the nature of the obsessions and compulsions. However, in general terms, OCD can be extremely debilitating, as we saw in the case examples, and impact a wide range of domains of a person's life. From an occupational functioning perspective, as an example, people are less likely and able to manage tasks of self care and house management due to the excessive time spent on obsessions or engagement in compulsive behaviors. From an interpersonal perspective, an example is that they are likely to present with interpersonal difficulties due to the impact that OCD has on those that surround the individual, persistent need for reassurance, and avoidance of events or activities. So, for example, continuously asking for reassurance from people can break a relationship, can impact on the relationship, but also actively avoiding meeting people when invited to their houses or public places obviously will have an impact, a detrimental effect on the relationships as well. From an educational and professional performance perspective, as an example, individuals with OCD have a higher rate of work absenteeism, and workplace productivity due to time-consuming obsessions and or compulsions and avoidant behaviors. So again, this could be the fact that they go home ever so often to see if the oven is off, or it could be the fact that they spend hours in the bathroom washing their hands due to fear of contamination. So, quality of life, as an example, people with OCD generally have lower socioeconomic status due to their professional impairments. So, they will need to access disability allowance as they're unable to perform professional tasks. They're less likely to engage in pleasurable and meaningful activities, and weakened immune system is also likely as a result of the anxiety, which obviously increases morbidity. How does anxiety impact on the person and those around them? So we're moving now to the people around them. Research suggests that more severe symptoms and impairments in everyday functioning in individuals with OCD result in higher impacts on their caregiver and family members. The impact of OCD on caregiver and family members might include feelings of hopelessness, so feelings that things will never get better, they will never change, significant physical and emotional investment to support your loved one, feeling tired and run down due to the constant obsessional and compulsive rituals, feeling overwhelmed, mental and physical health problems, so stress, anxiety, and depression due to that chronic exposure to those obsessions and compulsions, burnout, having financial difficulties as our loved one now is unable to withhold a job and therefore impacts on the household's financial status, family conflict, fear for a loved one's well-being, sleep disturbance, and lack of mental health service supports for family and caregivers. This list is not exhaustive. It is just an illustration, an example of some of the things that caregivers may experience when supporting someone with OCD. What other mental illnesses can mimic OCD? So many mental illnesses share similar and overlapping signs and symptoms. In order to effectively treat a mental illness, an accurate diagnosis needs to be made to inform the most suitable evidence-based treatment and intervention plan. With regard to OCD, other mental illnesses that present with similar signs and symptoms are as follows: anxiety disorders. Recurrent intrusive thoughts, avoidant behaviors, and repetitive requests for reassurance both occur in OCD and other anxiety disorders. However, whilst in anxiety disorders, the focus of the thoughts is usually about real life concerns, obsessions in OCD do not usually involve real life concerns and can include content that is odd or very theme focused, as we saw earlier. Depression. So persistent thoughts are present in both depression and OCD, unwanted, involuntary, and unpleasant thoughts. However, whilst in OCD, thoughts are experienced as intrusive or distressing and generally linked to compulsions, thoughts experienced in depression are usually mood congruent, so they're aligned with the person's mood and are not necessarily experienced as intrusive or distressing, as that they might not cause anxiety but only impact on mood. Eating disorders. So, obsessional thoughts and the need or urge to engage in ritualistic behaviors in order to reduce distress are present in both OCD and eating disorders. However, these are distinguishable by the fact that OCD is not limited to concerns about weight and food, whereas eating disorders solely focus on weight, food, and body image. Tics and stereotype movements. So, whereas compulsions are usually preceded by obsessions, tics are often preceded by premonitory sensory urges. So, again, changes in bodily sensations might lead to thoughts and might lead to behaviors in order to ensure well being, but it is not the same as compulsions, which are triggered by obsessional thoughts. Psychotic disorders. Lack of insight and thoughts that may seem bizarre or even delusional in nature are common in both OCD and psychotic symptoms and disorders. However, for individuals with OCD, they do not present with other features that are common in psychotic disorders, such as hallucinations and formal thought disorder. Other compulsive like behaviors. So, certain behaviors are sometimes described as compulsive, such as sexual behaviors, gambling, and substance use. These behaviors differ from compulsions observed in OCD in that the person usually derives pleasure from the activity and may wish to resist it only because of its deleterious consequences. So, in the case of gambling, while it might seem like an obsession and a compulsion, and the person has this strong urge to do it and does it, it does not cause any distress or anxiety, which would be the case in compulsive behaviors. How can someone know they have OCD? In the presence of signs and symptoms of OCD, especially when these are persistent and start to impact on daily life, seeking a formal clinical assessment by clinical psychologists and or psychiatrists is recommended in order to determine the severity of the symptoms and ascertain whether these meet criteria for a diagnosis of OCD. The first step would be to discuss this with your general practitioner, your GP, for additional guidance and support. They can provide immediate guidance, assistance, and make appropriate referrals to the right mental health services. I'd like to make a note here that many people who experience symptoms of OCD may not seek support, as this may be in itself anxiety evoking. Additionally, having to divulge personal information to someone who is unfamiliar can be very daunting for most people, especially for those who engage in avoidant behaviors or feel embarrassed by their obsessions. Again, for example, having sexual thoughts about your boss or about friends of the same sex if you're heterosexual. There are several assessment methods used by mental health care professionals in the context of signs and symptoms of OCD. These include validated questionnaires that can be clinician administered or be completed by the individual themselves, so self reported questionnaires. There are diagnostic interviews with individuals and their relatives and friends, sometimes even with members in their workplace if there are a lot of OCD symptoms in the workplace, monitoring and record keeping of symptoms, and physical examinations to make sure that there are no underlying physical conditions that could be leading to the current presentation and symptoms. The completion of these assessment procedures aid the mental health professionals in multiple ways. First, they determine the severity, frequency, intensity, and duration of OCD symptoms. They determine if the diagnostic criteria is met for OCD. They specify the level of insight that the individual has in their mental health difficulties, which will be extremely important for intervention. They help develop a case formulation, which is a theoretically based explanation of the difficulties, how these developed initially, and what is currently maintaining them. So they refer back to that OCD cycle we spoke about. They help the clinician in conjunction with the individual to set therapeutic goals based on what the individual would like to achieve from a therapeutic perspective. They also help delineate an appropriate intervention plan to reduce OCD symptoms. Assessment procedures are generally administered before and after intervention so as to monitor the progress of the therapeutic intervention and to see if it's being effective or if alternative treatment and intervention plans need to be considered. What comes after when someone has been diagnosed with OCD? So, someone you care for has OCD. Now what? Once a formal diagnosis has been made, there are several treatment options. Medication is one of them, and typically antidepressants or anti anxiety medication is administered to reduce the level of emotional distress. From a psychological perspective, the strongest evidence based therapy for OCD is called cognitive behavioral therapy, or CBT, which targets unhelpful thoughts and behaviors. One of the most important aspects of this therapeutic approach is what we designate as exposure and response prevention therapy. Clinical psychologists, counseling psychologists, and or psychotherapists with the appropriate expertise can support with this. It is the combination of medication with psychological therapy that promote the best therapeutic outcomes. So, how does psychological therapy for OCD look like? So, first, we would be addressing the thoughts. So, a lot of the thoughts that people have, as we can tell, are not necessarily accurate and real. Touching a doorknob may have, some germs, may have bacteria. We all know that. But the degree to which the person feels that touching that doorknob will result in them becoming ill and die, that is a distorted thought. It is not a real thought, or it's not based on real life and valid experiences and data. So, working together with the individual to develop their ability to generate alternative ways of thinking about a situation or viewing a problem is very important to reduce and address that obsessional thinking pattern. Exposure and response prevention therapy consists in supporting the individual in not engaging in compulsive behaviors when an obsession presents itself. This is a very difficult process and is built up very slowly, step by step. A hierarchy or a ladder approach is taken in that we support the individual to expose themselves to situations from least anxiety evoking to the most anxiety evoking. Mindfulness is another great psychological therapy used. The ongoing practice of mindfulness helps individuals with OCD develop the skill of non judgmental awareness and acceptance of present moment experiences, including those unwanted thoughts and urges that pop into their minds. And distress tolerance techniques. So, as we know, people with OCD can get very, very anxious and emotionally distressed, and they don't have the ability to manage that distress other than resorting to the compulsive behaviors. Distress tolerance skills will allow the individual to distract or self soothe themselves, so self soothe when faced with difficult thoughts, emotions, or urges, and might just be enough for them to tolerate that distress and discomfort without engaging in the compulsive behavior. When we look at the summary of intervention plan for OCD, really what we're trying to do is break that OCD cycle. So the obsessional thought that leads to the anxiety and that led to that compulsion, we know that that pattern there was not a good pattern and only led to the maintenance and well, worsening of the OCD cycle. So with the therapeutic approach that was just spoken about, the obsessional thoughts will be obviously leading to increase in anxiety. But if not engaging, if the individual does not engage in the compulsive behaviors, what we will see over time is that the obsessional thoughts will lead to less levels of anxiety, to the point that they will not cause anxiety at all, because the person has been able to see that they can overcome the situation without the compulsive behaviors. But equally, the obsessional thought might be exaggerated, unrealistic, or likely to be founded on information that is not valid or accurate. They will be able to challenge those thoughts and see things in a more realistic way. So, to summarize, in part one of this webinar, An Introduction to OCD, we talked about the difficulties experienced by individuals with OCD and the impacts of this mental illness on their overall functioning, as well as the people around them. You should now have a greater understanding of what OCD is and how it manifests, how thoughts lead to high levels of anxiety in OCD, the impacts of OCD on the individual and those around them, other mental illnesses that mimic OCD, how can someone know they have OCD, and what happens next when someone is diagnosed with OCD. Coming next, we will discuss in part two an introduction to OCD. How can you help? So, thank you very much for your attention and join me in part two next.